In this session, I am going to talk on a rare variety of ovary neoplasm, namely stromal tumours of the ovary. They are also called sesquioid stromal tumours or functioning ovarian tumor because most of them produce hormone, either estrogen or progesterone. Sesquioid stromal tumor arise from primitive sesquioids and or stromal cells of ovary. It constitutes about 8% of ovarian malignancies and mostly affect in young women or middle-aged women, but no age group is exempted. It can occur in girls as well as in postmenopausal women. The global incidence is 3 per 1 lakh women, and there is a 3.6% increase annually. Risk factors for this tumor is obesity, mainly if the BMI is more than 30 kg per meter square, and a family history of breast cancer, which will explain the annual increase for this tumor. Fertility factors are there also, like combined oral contraceptives and pregnancy. Common presentation in this set of tumor is the occurrence of a unilateral mass with a secondary endocrine manifestation. Hormone produced may be either estrogen, most of them, but a few like Leydig cells may produce androgen. And depending upon the hormones, that is hyperestrogenism and the age, the presentation may be starting from precocious puberty, abnormal uterine bleeding or postmenopausal bleeding, and in an androgen secreting tumor it may be presenting as fertilization, infertility or amenorrhea. Regarding most of these tumors present early, most of them in the stage 1 and had a good prognosis and are very sensitive to chemotherapy. The primary management is surgical staging, where the emphasis should be given for preserving fertility because most of these women are young, and there is no need for lymph node dissection. And now we will elaborate on a little detail regarding the different types of sesquioid. Granular cell tumor constitute about 90% of all sesquioid stromal tumor, and if you take the whole of malignant ovarian tumor, it constitute about 5% of all ovarian tumors. It produces estrogen, and symptoms of women who have this tumor, they have symptoms of hyperestrogenism. Histologically, there are two varieties, adult and juvenile. Adult is the most common type, constituting about 90% of the neoplasm, and a small percentage juvenile variety. These two types are similar in morphology and macroscopy, but differ in microscopy and molecular structure. The clinical profile of the woman and prognosis also differ in these two groups. Adult granular cell occur or originate from the follicular granular cell from the cells of the ovary. Granular cells, we know, is surrounding the ovum in the Graafian follicle and secretes estrogen under the influence of FSH and LH. FSH helps in aromatization of the androstenedione and testosterone into estrogen. Estrogen, in turn, have a negative feedback on the hypothalamus and hence on the FSH also, and that is how the secretion of estrogen is regulated. In adult granular cell tumor, there is a genetic mutation involving the gene for FOXL2. It's a single point missense mutation at C134W. The FOXL2 gene is active in proliferation, cell death, and tumorigenesis. And it forms a complex with SF factor, that is serogenic factor 1, to cause aromatization, and this factor SF1 controls or regulates the aromatization of androgens to estrogen. In granular cell tumor of adult type, the mutation results in inhibiting this seroidogenic factor 1, which result in upregulation of the aromatization, which result in hyperestrogenism. Granular cell, we also know it secretes inhibin A and B as well as AMH. Clinically, adult granular cell tumor mainly affect the perimenopausal and menopausal women. The most common age group is around 50 to 55 years, and even a history of breast carcinoma can be elicited in a high percentage of these women. Clinical presentation may be abdominal distension or bloating, or a mass abdomen. There may be pain, or they may present as acute abdomen due to torsion or intratumoral bleeding, which may present as intraperitoneal hemorrhage in 10% of the cases. Majority of these tumor, about 60%, are hormonally active and may result in the woman present with the features of hyperestrogenism depending on age of the woman. If it occurs in a girl, she may present with the precocious puberty, or in a reproductive age group woman, she may present with the abnormal uterine bleeding, or it may be with abnormal uterine bleeding may be heavy menstrual bleeding or even intermenstrual bleeding, and in a postmenopausal woman, it may be due to postmenopausal bleeding. Hyperestrogenism, we all know, have effect on the endometrium of the uterus, resulting in endometrial hyperplasia or endometrial carcinoma. And there is association of endometrial hyperplasia about 25 to 50% of the cases, and endometrial carcinoma in 5 to 11% of the cases. Tumor markers we usually use in this to distinguish this tumor as inhibin B and anti-Mullerian hormone, and the amount correlates with the tumor size. And after surgery, this will result in a rapid decrease in these tumor markers. It can also be used for follow-up, and in recurrence, it will again increase. Ultrasound will show a solid cystic tumor showing hemorrhage. It may appear as a spongy, wet honeycomb appearance in ultrasound. Macroscopically, the tumor looks like a solid lobulated tumor with a yellow tint due to the high amount of lipid with areas of necrosis. Microscopically, presence of colorectal bodies, coffee bean nuclei, and are classical features which distinguish it from juvenile type. Coming to management, surgical staging is the primary management, where we will do total abdominal hysterectomy with the bilateral salpinge oophorectomy, infracolic appendectomy. Lymph node metastasis is rare, even in advanced cases, maybe less than 3%, so there is no need for lymphadenectomy. But during surgery, due to the high friable nature of the tumor and hemorrhagic, chance of rupture is high and spill may occur. So great care should be taken to achieve zero residue, which will otherwise it will affect the prognosis. In young women, fertility sparing surgery, we can retain the uterus and the contralateral ovary if the uterus, ovary and the fallopian tube on the other side is not affected. That means the stage is stage 1A. And after the surgery, postoperative chemotherapy is required from stage 1C2. And the agents used the PEP regime, which constitutes bleomycin, etoposide and cisplatin. Other regime used is carboplatin and paclitaxel. Both regimes are equally effective. Majority of these tumors are detected in stage 1 and the prognosis is usually good, and the survival in stage 1 is up to 90 to 98% favorable. Adult granulosa cell tumor is an indolent tumor, that means very slow growth, and but it is notorious for late recurrence. Recurrence can occur even after 5 years, 10 years, even after 40 years it has been recorded, which requires lifelong follow-up. Follow-up is clinical evaluation with the tumor markers as well as by imaging depending upon the individual case. And the tumor markers may even start to elevate even very early before the clinical appearance of recurrence. Coming to the juvenile type of granulosa cell tumor, it constitutes about only 5% of the granulosa cell tumor, and the most affected is young women and girls, in contrary to adult type, which affect the middle-aged and postmenopausal women. 90% of this tumor occur in first 3 decades and 40% occur in less than 10-year girls. But it can also occur in all age groups, even in menopausal women. The clinical presentation and macroscopy are just like in adult granulosa cell tumor. 30% of the juvenile type doesn't produce any estrogen, but the absence of estrogenic symptoms does not exclude juvenile granulosa cell tumor. As in adult type, tumor marker are inhibin B and anti-Mullerian hormone, and if there is hormone is produced, there will be endometrial pathology may be associated. How to distinguish between adult and juvenile type? Mainly by microscopy and the biomolecular characteristic. Microscopically, there is a diffusely arranged tumor cells in sheets or nodules with varying percentage of cystic and follicular spaces. The cytoplasm is eosinophilic, immature nuclei with nuclear atypia, increased mitosis, increased nuclear cytoplasmic ratio. Immunocytochemistry is positive for calretenin and inhibin. In contrast to adult type, there is absence of collectional bodies and coffee bean appearance of nuclei. And biomolecular, here the mutation is a somatic AKT1 mutation, and there is no FOXL2 mutation as in adult type. These are the distinction features of juvenile from the adult type. Coming to the management of juvenile type of granulosa cell tumor, primary management is surgical staging, where we do a triage with the BSO, a mendectomy. There is no need for lymph node dissection. Majority of the women being in the young age group or girls, fertility preservation is paramount importance and can be done in stage 1A. But remember, if there is evidence of hyperestrogenism, and endometrial pathology should be ruled out prior to conservative surgery. Most postoperatively, chemotherapy is recommended from stage 2 onwards. In stage 1C, with risk factors, chemotherapy may be considered. The risk factors are high mitotic index, that is more than 20 per high power field, nuclear atypia, and capsular tumor on the capsule of the tumor. The regime used is bleomycin, etoposide, and cisplatin. In advanced stages, anti-androgenic drugs and radiotherapy may improve the outcome. Juvenile granulosa cell tumor has a rapid clinical course. Most of the recurrence occur within 3 years. The risk factors are advanced stage, high mitosis, and the type of surgery, whether there is any residual disease present or not. Follow-up is as in other ovarian cancers, and is by the tumor markers may be used for follow-up and clinical evaluation. Sertoli Leydig cell tumor is a rare type of primary ovarian tumor constituting about 0.2 to 0.5% of all ovarian tumors. Most affected is a woman less than 25 years. Of course, it can occur at any age group. Women usually present with abdominal mass, abdominal pain, or pressure symptoms, or they may come for evaluation of amenorrhea or infertility. 50% of these women may show hormonal symptoms either due to androgen, where they may present with amenorrhea, oligomenorrhea, hirsutism, or even rarely with virilization. A few percentage about 7% may have symptoms of hyperestrogenism like irregular menstruation, precocious puberty, or in menopausal women, postmenopausal bleeding. In hyperestrogenic women, there may be associated endometrial pathology may also be present. 67% of the women may be showing elevated testosterone level, which may be used as a tumor marker. Other tumor markers, CA125, alpha-beta protein, CA19-9, may be elevated in 20% of cases. Most of them clinically present as a unilateral solid mass, which is lobulated, having a smooth surface, and the cut section show a solid mass with a yellow tinge. Microscopically, there you can see presence of testicular structures like Sertoli cells, Leydig cells in varying degree of differentiation. Tumor may show heterogeneous element and reticular pattern. The degree of differentiation, the heterogeneous element and reticular pattern are prognostic indicators. Intermediate and poorly differentiated may be mistaken for a sarcoma. Well differentiated with a uniform histology and low mitotic figures behave as benign but rare compared to intermediate and poorly differentiated. Coming to the biological molecular characteristic, DICER1 mutation is seen in majority of the cases. It can be a germline mutation about 69% of the cases, or it can be a somatic mutation in 29% of the cases. DICER1 mutation is responsible for gene expression and by producing mature microRNA. And this gene is expressed in granulosa cells, and its decreased production may result in decreased ovulation, decreased ovarian function, and resulting in infertility. Coming to the management, surgery is the primary option, and since majority of these women are young, fertility sparing surgery is given great care, where we do during surgical staging, we do ovariotomy of the affected ovary, multiple peritoneal biopsy, infracolic appendectomy, and there is no need for lymph node resection. Remember, DICER1 mutation is associated with renal and urethral abnormalities, and during surgery, care should be taken not to injure these structures. Postoperatively, from stage 1C onwards, require chemotherapy, and the preferred regime is BEP. In earlier stages, If there is risk factors like higher grade, heterogeneous element, or a reticular pattern in microscopy, these are risk factors, and hence chemotherapy may be considered. Most of the women present in stage 1 and has a good prognosis, about 92% survival. Dicer1 gene germline mutation has good prognosis, whereas somatic mutation has no effect on prognosis. To conclude, stromal tumor, otherwise called functioning ovarian tumor, is a rare variety of malignant ovarian tumor. Most of them produce hormone, either estrogen or androgen, and have present with hyperestrogenism or virilization. And majority of the women affected may be young women, and for them there is an option of fertility preservation, and during surgery there is no need for lymph node dissection. And if you are going for a fertility conserving surgery, always remember there may be associated endometrial pathology. It should be excluded by a dilatation and curettage. Majority of these tumors present in early stages, and the prognosis is very good. And in the case of adult granular cell type tumor, which is an indolent tumor, and recurrence can occur as late as 40 years, hence lifelong follow-up is necessary in adult type of granular cell tumor. Thank you.